The broadcast is now starting. All attendees are in listen-only mode.
Well, hi there. This is your moderator, Lori Dearman, and you're in the right place for monitoring technology provides vital information to help boost community service levels and occupancy rates. Featuring Elizabeth Newman, Senior Editor at McKnight's Long-Term Care News, and David Stern, Product Manager at Quiet Care. As content producer with WebAttract, I'll be moderating today's session, and in just a moment, I'll be introducing our speakers, as today's webinar is about hearing from these experts as they address trends, challenges, and benefits that await communities who have strategy for deploying technology to improve outcomes and provide a higher level of personalized care, as well as share expertise on using an innovative wireless monitoring system that can provide vital information to enable communities to practice early intervention. You'll also have an opportunity to have your questions answered at the end of the presentation during the Ask the Experts panel session with both panelists. But for now, let's get started as we have a lot to cover. Now, speaking of feedback, I would like to go to the first poll we have for you today. So coming up on your screen, you should see a question, which is what type of monitoring technology interests your community? We'd really like to know what type of monitoring technology interests your community. Is it wandering, falls, medication management, sleep quality, staff member recognition and accountability? So go ahead and weigh in on that, and I'll be sharing those out with everybody in just a moment. Okay, looks like just about everybody has weighed in, so let's go ahead and take a look at those results. Looks like we have just about 61% for wandering, 69% for falls, 59 medication management, 33 sleep quality, 47 staff member recognition and accountability. So thank you all for your input, and I think without further ado, we'll go ahead and meet our featured presenters. So as I mentioned, I'm very excited to have joining us Elizabeth Newman with McKnight's Long-Term Care News, as well as David Stern with Intel GE Care Innovations. Elizabeth will be starting things off for us today. So before we let her go ahead, how about a few words in the way of an introduction? Now, Elizabeth is Senior Editor at McKnight's Long-Term Care, which she joined in 2011. And she was previously the Editorial Manager at LifeBridge Health in Baltimore. Before that, a reporter for Capital Gazette newspapers in Annapolis. She's a graduate of Northwestern University Medill School of Journalism, and as a Virginia native, Elizabeth today lives in Chicago with her husband. So welcome to the webinar, Elizabeth. How are things in Chicago?
Things in Chicago are beautiful. Thanks for having me, Lori.
All right. Well, I'm very much looking forward to hearing your thoughts on today's subject of technology for assisted living. So at this point, it's all yours. Over to you.
All right, well, thanks for being here, everyone. As Lori mentioned, I'm the Senior Editor at McKnight's Long-Term Care News and McKnight's Assisted Living, which are business-to-business publications for the industry. And while I work more on the long-term care side, those of us here at McKnight's have seen some interesting things happen with assisted living that I'm excited to talk to you about today. Now, I wanted to give you a sense to start off with of what's most popular among our readers. These are the top stories in May for McKnights.com. So obviously reimbursement and regulations top the list, and I'm going to make the case that technology can help you with those. I want to make it clear that we don't endorse any specific products or services, and we try to act as objective observers of the industry. Now, of course, you'll also see on this list that while regulations and policy are generally the most popular, news of the weird, such as your gun-toting clowns, will also result in a lot of eyeballs. So what are the big questions right now? One is the future of payments, such as your case mix, and of course the other is what's going to happen with federal regulations and state regulations. Now, it's not a surprise to anyone here that these two can overlap. And of course, the question for today is what role will technology play? So greater numbers of people are choosing assisted living or CCRCs, and of course you have to keep in mind that there are varying definitions of what assisted living is depending on what state you're in. And while the number of continuing care retirement communities is small, it's growing, and I also want to note that we hear from them more in terms of telling us about their success stories, and that's something to keep in mind as you look to promote your success stories. Now, as we've seen through NIC MAP data, assisted living occupancy rates are doing okay. We see here that assisted living units saw a 57% increase in calendar year 2010. And of course, traditionally assisted living was seen as the private pay alternative to nursing homes. In 2007, an interesting study in Harvard, researchers found that a 10% increase in assisted living occupancy rates was associated with a 1.4% decline in private pay nursing home occupancy. As you can see on this slide, SNF bed prices are falling and occupancy rates are marginally declining over the past couple of years. Now, there's been a big demographic shift in both areas. Much as skilled nursing residents have increased levels of acuity and multiple comorbidities, assisted living residents have grown older and sicker. Half to two-thirds of communities offer case management services now. At the Alpha conference this spring, there was a panel on this topic, and the panelists said that the line continues to blur. In assisted living, we can see more patients who need PT or OT, who are considered high risk for a hospital visit, or who have some form of dementia. Staffing ratios, training levels, care systems may not have adequately changed to keep up with this. At a roundtable last fall, a head of a Midwest nonprofit group told us that skilled nursing facilities are going to look like hospitals in less than 2 decades. The average age will be around 92, and that there's going to be a big push to get physicians and nurse practitioners on board. So what does this mean for you? The buzz out of the Alpha conference was how more assisted living groups are going to look at participating in accountable care organizations. Long-term care institutions thus far haven't been leading the charge on forming ACOs, but they're seen by CMS as the only way that they're going to work. This to me feels a little bit like high school, where hospitals are the cool kids, your Molly Ringwalds, if you will, who are trying to get to decide who gets to go on the senior class trip. And there's a not entirely unparanoid fear that if ACOs work and if payment incentives come around, the physicians and the hospitals and the cool kids will be the ones with the glory. And if that they don't, it's long-term care organizations who are going to be the ones blamed. But there's still no getting around the fact that care coordination and cooperation are the big buzzwords right now. And this can tie into your state's Medicaid program. As you know, assisted living is largely regulated by the states, and some states have allowed assisted living groups to accept Medicaid residents. Right now, about 19% of assisted living residents are getting Medicaid assistance, and 43% have at least one resident on Medicaid. We've seen some big changes in places like Georgia, South Dakota, North Carolina, and Nebraska. South Dakota overhauled its rules. In 2011, all New Jersey assisted living Medicaid recipients must choose a healthcare provider from within a managed care network. In Colorado, the Medicaid agency is making changes intended to ensure that assisted living facilities serving Medicaid clients are home-like and integrated into the community. Rhode Island substantially reduced state supplemental security payment benefits for assisted living residents receiving supplemental security income. So you really have to keep up with what's going on in your state. As you see those changes at the state level, there's a lot of feeling that that's where assisted living regulations should stay. There are two viewpoints on federal regulations. One is that it's inevitable at the point where federal regulators are paying for assisted living services, that all it takes is one ambitious lawmaker to say, we should have a hearing on this, and it sets off this multi-year process for increased assisted living federal regulations. Keep in mind, I'm not saying that's how it should work, I'm just giving you a scenario. An example of how this may come about is what we've seen with antipsychotics, which are used in both SNFs and assisted living, but it's really getting a lot of legislative attention on the SNF side. To fill you in case you missed it last month, Senators Herb Kohl, Chuck Grassley, and Richard Blumenthal proposed a regulation that would have standardized protocols for obtaining informed consent before administering antipsychotics for off-label use. Now, this legislation was tabled, but the point that I want to make is that it's not like those senators woke up last month and said, oh my gosh, this is a problem. There have been years of studies and stories and initiatives and bills, and now I think we're at a tipping point where CMS says they're going to make the data on antipsychotics part of Nursing Home Compare, they're going to provide additional training, and it's a topic everyone's talking about. And I suspect this legislation may come back. Nothing's going to happen before the election. But this ties into my gentle reminder that federal regulations often result from what gets bad publicity. Don't let the bad publicity happen to you. Because while you can hate the media as much as the next person, when a fire kills a bunch of nursing home residents, my people are going to be there. You can see in 2003, there were a bunch of nursing home fire fatalities. Now we're seeing these federal regulations for sprinkler systems where nursing homes have to install sprinklers by August of next year. Huge problem for a lot of facilities. In my state of Illinois, there are 278 facilities that don't have sprinklers yet. They have a year to get there. CMS has been pretty clear that an extension is not expected. So this ties into my issue of there are the things that you can control and then there are the things that you can't control, right? But once the government's invested financially, we could see some more laws. The flip side is that the head of Alpha says this is never going to happen and that states are doing fine regulating assisted living. So when we're talking about these issues beyond your control, which are to a certain extent legislation and the economy and stuff like that, there are some things that we can agree that you may be able to control because you want a high census, you want a good case mix, you want lower staff turnover. And I put this survey up here because I thought it was interesting. It was from the Residents Financial Survey, looked at 2,600 residents across 158 communities, and the majority of respondents said they either strongly agree or agreed with the statement, the community offers me good value for my money. But when you looked more closely, only 15% said they strongly agree. How do you boost that? I would make an argument that you look at your technology. Right now, we can see that a lot of technology is in silos. We can see plant management software and database reporting and general ledger is all in its own little fiefdoms. When you're in a SNF or assisted living, there are the things that people can see and care about, and then there are the things that make your life easier. So scheduling software is a really good example of the latter. Consumers don't care unless it affects them, but that can save you money. No one may ask you about your electronic health records, but you have to ask yourself for how you're going to put them in place and have interoperability with a SNF or a hospital because it all goes back to this idea of care coordination, bundle payments, ACOs. So when we talk to our readers, here's what we hear that they're looking at. When the savvy or the non-savvy customer approaches you, of course you want to stress your high-quality invested staff. But anyone who has a parent or a loved one with wandering issues is going to want to hear about your security and your wandering management systems, maybe your monitoring devices, maybe the training that you do for your staff. I suspect some of them may also ask about privacy and communication. Let me be clear, I'm not advocating that you spend a lot of money just to have something flashy, but I do want to point out that when you compete with these high-end communities, you will see very large examples of electronic recording and very discrete examples of security monitoring, and it looks impressive. Your customers may also want to know about fall detection. As you may know, falls are the leading reason residents end up in the ER and rack up a cost of $20 billion per year in the US alone. There's a lot of data that indicates around 10% of falls can be prevented through everything from low beds to positioning strategies to monitoring technology. And of course, your consumers may not have these statistics at the ready, but they may know that a loved one had a fall and then it was all down here from there. And so my best piece of advice is that resident safety shouldn't be in a silo system, because this is an area where it's really worth spending some time figuring out what will work best for your community. I will also point out, though, as with all things technology, you have to talk to your nurses and your staff. Many CEOs have told me that without nurse buy-in, they are toast. Another question for your community is the question of your online presence. For the past few years, there have been a lot of people making a lot of money talking about how amazing social media is. And I'm not knocking social media. It's a great way for you to interact sometimes with your future customers. But you have to have a decent website. You have to have your phone number and your address on it. You need to have information that people are looking for, such as what your continuum of care is and what services you offer. Pretty much what's in your brochure, it should be somewhere on your website, and it should be easy to navigate. And I can't stress this enough because this is one of those things where you have to walk before you can run. You have to start with the basics of a really solid website. Now, whether it's your website or your monitoring, this brings us to the question of data analytics, which is a term that makes my heart go pitter-pat. Traditionally, a lot of what any of us did, whether it was in journalism or long-term care, was by instinct. In my newspaper days, this went along the lines of, oh, people love that story, it has a dog in it, let's put it on the front page. So now we have the tools and honestly sometimes the financial incentives to make a case that's based not on emotion, but on the data and how it's going to pay off. But, and this is a big but, you have to use the data to make good decisions. It's not a magic button, no technology is. A corporate executive board report that appeared in the Harvard Business Review said this year that more operators need workshop training and coaching so that they can do this. It talked about how a lot of organizations lack a coherent, accessible structure for the data they've collected, and about half of the employees say they can't find the data on a day-to-day basis. I also want to point out that anecdotally, we hear a lot about data correction going on in long-term care, and this is along the lines of, oh, I'll just fix the code, or I'll just fix the date, or I'll just fix the record. And you have to communicate back about what the error was. You have to go back to the data creator when the data is wrong. Now, when you have this lovely, pretty data, this can help you in a number of ways. This can tie into your lobbying efforts and your customer recruitment, because you want to be able to talk to your suddenly interested lawmaker and talk about how you're tracking residents and how you're spending the money and how you're being efficient. And you want your assisted living staff member to be able to say, we've looked at the numbers and your mother's having a hard time sleeping. There's also a case to be made that you need to invest in employees to learn how to do data analysis and let them see some of the data to empower them to make small changes which can really make a difference. Monitoring software and data should not exist in a vacuum. So I'm really interested to hear what you all have to say. We'd encourage you all to sign up for McKnight's Assisted Living or McKnight's Long-Term Care News. Please consider signing up for a McKnight's Technology Awards program. This is a competition for providers that we recently extended the deadline for, so now you have until July 27th to apply. And I also would encourage you to reach out to me through the sites below. You can follow me or the magazine on Twitter. And I'm going to hand it back to Lori now, but look forward to taking your questions.
Well, thank you very much, Elizabeth. That was excellent. And folks, we'll be putting that contact information in through the chat at some point during the webinar, so you'll have that handy as well. And now I'd like us to turn our attention to David Stern. And David has been involved in social services for more than 40 years and is currently the product manager for Care Innovations Quiet Care. He's served 12 years as Executive Vice President, CEO of the Jewish Association for Services for the Aged, which provides an array of services to over 53,000 elderly in the New York City area. He's also been a commissioner of Leading Ages Center for Aging Services Technology, a member of the Technology Advisory Group of the CMS-funded Aging Services Technology Study, a fellow of the Brookdale Center on Aging, as well as a member of the Technology Committee of Age Friendly New York. He writes and speaks extensively on aging, technology, and related public policy issues. Now, David today is going to be taking us through some use case scenarios and sharing some lessons learned by the communities that he's worked with who have implemented passive monitoring technology. So, David, over to you.
Thank you, Lori, and thanks to those of you who are joining us out there. I'm really privileged to be on the panel today with Elizabeth Newman and to gain her insights about the issues facing assisted living and the potential of technology to help address those. Today, I'll be talking about some case examples from the field about how technology is helping to transform assisted living communities right now. These case studies will be drawn from one technology. It's a mouthful, passive activity monitoring systems, sometimes called sensor technology. But we believe that many of the lessons learned are applicable to the use of other technologies. We will also examine the processes that ALs used in successfully selecting, introducing, and integrating technology into their operations. But please realize that this presentation is not just about technology. As Surgeon General Koop once said, medication doesn't work unless you take it, and we should realize technologies don't work unless we use the information it generates. So this presentation is really about how dedicated staff members have used technology to improve care, staff performance, and increase revenues. To facilitate our discussion, please permit me to refer to each one of these people as George. Actually, one of them is George, and to use these examples to help you understand how technology is currently being used.
Now, David, understanding that we're not here to learn all the bells and whistles of various technologies, but for folks on the webinar today who might not be familiar with the concept of passive monitoring technology, can we take a moment to just give a quick overview of what it is and how it works?
Thank you, Lori. I think that would be very helpful. Maybe we first should look at the term passive. The system is completely passive in the sense that the resident doesn't have to wear anything or push any buttons, nor is it dependent on any physical, cognitive, or language capabilities. In this way, it helps ensure full compliance. Sensors are strategically placed around the apartment. As the resident moves about their home, they activate the sensors, which then relay the activity data to a central computer. The data is analyzed and two types of reports are generated. One identifies potentially urgent situations. For example, an extended stay in the bathroom that might be indicative of a bathroom fall. The system then promptly sends alerts to staff. The other kind of information that is generated identifies notable changes in daily activities. In addition, comprehensive reports on the residents are available on a password-protected website.
Now, how about we take a look at some of the real use case scenarios so we can kind of see it in action?
That's good. And let's start with some sort of behavioral kinds of information. Our first example demonstrates how technology identified a change in activities which indicated the onset of a disease. There was a significant increase in a resident's nighttime bathroom visits, and that generated an alert. A urine test was ordered and performed, and it was determined that the resident had a urinary tract infection. Because of the early detection, no hospitalization was needed, and the resident was placed on oral antibiotics. The ED monitored the resident's progress by checking her daily bathroom activity report. And he continued to do this until her bathroom visits returned to normal. Now, it's important that we note that activity monitoring technologies don't diagnose. They provide timely, accurate, actionable information to clinical staff who can use their professional judgment to respond to residents' changing conditions. Another example comes from an assisted living community in New Jersey.
At 1:32 a.m., an aide in a New Jersey assisted living community received an alert indicating that a resident had had a prolonged bathroom visit that might be indicative of a fall. She went to the resident's bathroom and found her on the floor, bleeding profusely from a scalp wound. She immediately called 911, and the EMS arrived within minutes. The resident was taken to the hospital, where her wound was sutured, and she was admitted for observation. 2 days later, she was able to return home. The technology not only may have provided life-saving information, it documented the timeliness of the caregiver's response. Please note that the next scheduled bed check would have been 3.5 hours later. The above are only two examples. In addition to monitoring the onset of disease and potential falls, sensor technology can be used to identify wandering, failure to get out of bed and move about in the morning, night motion, sleep disruption, extremes of household temperature, and interaction with the area in which medications are stored.
Let's now look at 3 more case studies. These reflect uses we might not normally associate with activity monitoring technology. We'll consider how technology was used to improve communication with family members, how it was used to establish trust, and how it was used to improve staff performance and strengthen community operations. Pinecrest Village has a policy that the executive director call family members at least once a month. George wanted to make these calls more substantive, to provide updates on how the resident was progressing, including any problems they were having. George chose to use each resident's technology-generated weekly overview, that's a mouthful, and you have that in front of you, as a basis for his discussion, and would then send these out to the family in advance. Let's look at one resident, Jesse King. The data is real. The name and other identifying information has been changed. As you look at the report, you will note the red bullet for the nighttime bathroom visits on Tuesday, 9 times. This is a significant increase for a resident who normally goes 2 or 3 times a night. George explained to the family that the resident had an upset stomach, noted that his staff was there and accompanied her to the bathroom, her frequent visits, to avoid falls, and provided her with liquids to keep her hydrated. As you can see by the graphic, by the next night she was fine. George was able to demonstrate his concern for the knowledge of the resident, reassure the family members about the care being provided, and give recognition to the responsiveness of his staff. This made the care real. The value of such communication should not be underestimated. According to Bruce Dimitro of CNA, the 2 leading underlying causes of litigation against assisted living is lack of documentation and poor relationships between assisted living and family members. George once told me that the most important element in his relationship with staff, residents, and families was trust. Here's one example of how George established trust. A resident returned from the hospital with a clamshell brace around her torso and a prescription that she receive assistance with toileting. This would raise her care level with a resulting cost increase of $1,800 a month. George informed the resident's son, who agreed to pay for the higher level of care. Staff was informed of the change in care plans, but subsequently, when George was reviewing the choir care data, he was alarmed to realize that the resident was not receiving assistance. He went to speak with her, and she informed him that she wasn't signaling for help because she didn't need it. George contacted the hospital, George was also an attorney, and asked that the resident be reassessed. She was and was found capable of managing on her own. George notified the son that there would be no rate increase and explained the role that technology had played. The following week was family night, and the son told all the others there how George used technology to save him $1,800 a month. Of course, they each asked George to look at the technology to see if it could give them savings. George explained that the technology provided them with greater insight into the appropriate care level needs for each resident, but they should be aware that that could result in an increase, a decrease, or an increase. Over the next 3 months, with little pushback from family members or residents, George increased care levels and fees $114,000 on an annualized basis.
Now, George, I'm already calling you George.
You can call me George.
David, these are really informative examples, and I think that that they're helpful for folks to consider. But I'm wondering if you could also share with us the process that these folks went through to decide to adopt this type of technology.
Laura, I think that would be helpful, and believe it or not, our next slide addresses it. George was hired as the executive director to turn around a failing assisted living. Occupancy rates were at 54%, staff turnover was high, morale was low, resident satisfaction was barely okay. And to make matters worse, 5 miles down the road, there was a new palatial assisted living with a big marketing budget. George knew he couldn't compete on those terms. Instead, he decided he would create a caring community. He would increase occupancy by generating referrals from satisfied residents and their families. To do this, he would need to find ways to improve staff performance, recognize their good work, create a warm, home-like atmosphere, improve care, and improve the assisted living's relationship with residents and family members. George sought a technology that would help him achieve these objectives, a technology that signaled a needed change in the institutional culture and a commitment to accountability and a higher standard of care. Given the limited technical skills of his staff, he would need a technology that was easy to use and provide information that was intuitive and actionable. He chose passive monitoring. In addition to meeting his goals, George believed that the sensors on the walls were a visual symbol of his AL's commitment to care. But he also needed a company that would not just sell him the technology, but help introduce the technology to his staff, his residents, and family members, to help in the installation and adoption process, and to provide ongoing support and training. He interviewed the clinical support personnel and the installation team, and he was satisfied. But the technology was only a portion of how George created change. He introduced it, he spruced up his community, put a popcorn machine in the lobby, and every time you walked in, you smelled the fresh popcorn. He put out coffee and cookies. He created a warm and inviting atmosphere. He improved the menus, and he brought his dog to work. And finally, he added new plantings to the garden. Initially, George and his director of nursing daily consulted with the vendor's clinical support team to review generated data. But within a couple of weeks, they were doing it on their own. George particularly focused on the night shift, where there was limited supervision. When he saw, in quotes, that a staff member promptly responded to an alert, he sent a thank you note, put a copy of it in their personnel folder, and commended them at staff meetings. Soon, staff were heard commenting, "George knows everything that's going on." Overall, staff responsiveness was up sharply, and a corporate survey of residents found satisfaction levels dramatically higher. 47% of new residents were referred by existing residents and their families. 18 months later, the community was full and had a waiting list.
Wow, that's pretty impressive. In 18 months, he went from 50% to 100% occupancy. That's really impressive. And I'm wondering, what lessons can we draw from all of these examples?
Well, I think, first of all, we have to prepare for technology. We have to be clear about our objectives for technology. We have to ask ourselves, does it fit our organization's mission and culture? And we have to define what outcomes we are seeking. Technology should help us achieve and even enhance our vision, but not deflect us from it. We need to engage key stakeholders, our board, maybe a corporate office, staff, residents, and family members. We need to listen to them and address their concerns. And we have to be careful not to overpromise results or underestimate the efforts that will be required. We need to gather intelligence from existing users, visit them if possible, assess the risks associated with technology, and identify and address barriers to adoption. Finally, we should consult with our insurance carrier and our legal counsel. We also have to assess organizational readiness. I don't have to tell anybody in our audience that change is not easy, and therefore it is crucial that we honestly assess our organizational readiness. We have to look at our strengths and our limitations, and like George, develop a plan that works for our community. Are we and our staff ready to make the operational changes necessary to take advantage of the technology? Does our staff have the skills and competencies to utilize the technology? We must not be careful not to underestimate the work in transforming our community. George pointed out to me that initially he spent long hours and sometimes 6 or 7 days a week assuring that the adoption and integration of the technology was taking place. But as he noted, quote, "After that, it was on cruise control, and I just have to tweak it every couple of months." So probably the most important factor in assessing organizational readiness is, do we have a champion? Someone who believes in the technology, has the capacity to manage it, and who is respected by their colleagues. If we don't, we're not ready. Now let us look at how some communities have assessed technology. As Elizabeth mentioned, industry change trends may result in increased accountability and regulation in assisted living. Although these are not likely to happen overnight, we might want to consider them and plan for them in our assessment process. Do they meet regulatory, FDA, safety, UL, and quality standards? Do they provide for data security, privacy safeguards, backup storage, and HIPAA compliance? Does the provider offer initial and ongoing training and support for our technical, clinical, and caregiving staff. Remember, most of us are 24/7 operations. Will the technology be responsive to evolving needs? Will the company help us manage the institutional change that's necessary? Will it enable us to create a facility of choice and enhance our market share? Ideally, technology should support rather than supplant staff judgment, and caregiving focus should be user-friendly and responsive to staff needs, and solve problems rather than create new ones. Now we've done our preparation, we assessed our organization and the technology, we've involved our stakeholders, and now it's time for the launch. Well done, the launch can help facilitate adoption. If problematic, it can erect barriers to future acceptance. So it is important to review and reinforce plans for the scheduled installation with residents and staff. Stress to the installation team the importance of being respectful of our residents, of their privacy, and their property. Mobilize our own and vendor staff to support installations. Our clinical leadership and the vendor's clinical representatives should accompany installers to answer resident and staff questions. And these answers should focus on how information from technology will be used to improve care, respect privacy, and help staff be more responsive. We should plan our post-installation ongoing training and support, and we should celebrate and publicize technology-related successes. Recognize staff for using technology generation to improve care and performance, and seek local media recognition, and have real case examples to demonstrate why our AL is providing extraordinary care and is a facility of choice. Hopefully, from these lessons from the field, you've been able to see how technology has empowered caregivers to detect problems early on, leverage information that enables seniors to be independent longer, achieve higher occupancy rates and revenue, and increase retention of seniors and staff. But beyond the vignettes, there is hard data. For example, studies from Quiet Care have demonstrated increased net revenue, 29% increase in service care plan levels, 58% fewer falls, 60% increase in length of stay, and many instances where health concerns, such as UTIs, were addressed proactively. Finally, as you consider technology, please think about how technology can help you achieve and perhaps broaden your goals and objectives. How you can do well by doing good. These are exciting times with great opportunities to improve care and your bottom line. If in your journey in selecting the appropriate technology to meet your community's needs, you want to talk or consult, please feel free to contact me at my Care Innovations email address. Thank you again, and now let me turn it back to Lori.
Oh, David, thanks so much for sharing with us those use case scenarios as well as your expertise in implementation and assessment. Now, don't go too far. We'll be calling you back in just a moment to answer some of the questions that are coming in and also to weigh in on a poll. So speaking of polls, folks, coming up on your screen is the second of our polls for today. And we'd like to know from you, what is the biggest challenge related to implementing monitoring technology in your community? So what do you think would be the biggest barriers or challenges? It looks like just about everybody has weighed in, so let's go ahead and take a look at that poll. We've got 60% saying budget availability is the biggest barrier, followed by 18% saying technical integration with other systems, following closely at 11% resident receptivity, then 9% say staff training, 4% lack of industry standards. So looks like budget availability is coming in with the largest here. Does this surprise you, David?
No, I think it's understandable. It also may reflect the audience out there who is probably very knowledgeable in technology and interested in adopting it.
Yeah, I think you're probably right. So thank you everybody for weighing in on that. Before we get to our questions, just want to leave you with a few bits of information in terms of next steps that you can take to get more information on this topic. Certainly welcome you to sign up to receive the McKnight's magazine, the URL on the screen. Again, we'll be putting that through the chat again shortly. If you would like to request a copy of the Quiet Care ROI study that David mentioned in his presentation, you certainly can email Quiet Care at the email listed. And if you'd like to set an appointment to learn more, you can use that email address or simply call the number here on the screen. I'm going to have it on the next screen as well, so no worries about getting it all in there. At this point, I would like to call both Elizabeth and David back to our virtual podium, and we're going to start answering the questions that have come in. So I've got one here from Jill, and would like to know, how do your communities pay for this type of technology?
Thank you, Lori. We've seen basically in our experience 2 ways. One is they pay for the technology by passing the cost on to residents, or some of the cost, because of the increased level of care they'll be providing by using the technology. More common is that the community absorbs initially the cost of the technology, but through ROIs, raising care levels, for improving occupancy, for a whole bunch of reasons, they're able to generate more than enough revenue to offset the cost.
Okay, thanks so much, David. And this one looks like a good one for you, Elizabeth. And Bob's asking, if Obamacare affordable care is declared unconstitutional, what will change, in your opinion?
That's a question on everybody's mind this week, Lori. But Don Berwick spoke this morning at the Health Lawyers Association meeting, which happens to be here in Chicago, and he was talking about how the train has really left the station on a lot of these reforms. When we talk about bundled payments, when we talk about care coordination, it's really believed that that's the future. You may, if it's repealed, you may see some, or declared unconstitutional, you may see some minor things happening that will affect day-to-day life. But really, I mean, I would really tell people that you need to kind of be looking at how to use technology in a way to be efficient, and be looking at who your partners in care can be as you move forward.
Thank you so much, Elizabeth. And got one here in the queue for you, David. And Claude is asking, how may these monitoring technologies be used to extend services from central facility to local community?
That's really a very interesting question, and one that has sort of become a hot topic. Many communities are exploring virtual assisted living, not to be encumbered by their bricks and mortar, but be able to help people to age in place. It varies with the technology, but in many cases, these technologies have versions of them that enable you to install it in individuals' homes. So the same kinds of information you get from in an assisted living community or independent living community, you can get remotely from the sensors and the technology installed in the homes.
All right, thanks so much. And got one here for you, Elizabeth. And Samuel would like to know, what's the biggest topic that's being talked about? So what's the hot topic right now?
I'd really say it's this question around regulations, Lori. This is what people are kind of, I don't want to say fighting about, but just talking a lot about. There are a lot of efforts to try to keep these regulations on the state level. But, one of the things I think that David kind of talked about is that, there's something to be said for being proactive and not waiting until there's, an industry regulation where you have to do something. I mean, the analogy goes back to kind of sprinklers and kind of getting those in before the deadline is upon you, even with some of those budget concerns. So regulations, state, federal, is really what everybody's talking about in these circles right now.
This one for David, and Dustin's asking, David, what have been the biggest lessons learned in the new space of using technology for activity monitoring, and where do you see things going in the next few months or even years?
That's a tough question. I think actually one of the lessons I learned was that it wasn't really about technology. It was about how people use technology. And but I think that what we're seeing is yearly advances in this kind of technology. And I foresee in the not too distant future being able to passively identify falls anywhere in a home. I see that being able to integrate, especially if you have a Zigbee network, information from appliances that are also Zigbee enabled. That's a wireless communication platform. I think we're going to be seeing the ability to take advantages of embedded technology. I'm not sure any of this is going to happen in the next year or two, but it's going to happen. And we will then be able, hopefully, to offer, as one of the inventors of our system mentioned, a dumb smart house. And he didn't mean dumb, he meant affordable and cost effective, so that we can really help people to have a safe environment and age in place.
Okay, thanks so much. And this one for you, Elizabeth. And Bill is asking, how do I find out about or follow legislation specific to my state?
Well, in McKnight's Long-Term Care News, we do have a state news section where we kind of look at some of those issues affecting different states, but I'd really encourage you to connect with your state organization, and that's really the best place to find out about what's going on at the state level. Because as I mentioned, I mean, a lot of these can vary a lot from by state. So really connect to your local leading age group, your local OCCA group, your local assisted or your state assisted living group.
And I've got one here for you, Elizabeth, from Melanie. And Melanie's asking, in some states, they're trying to allow assisted living facilities to take people with more and more acuity. And in other states, it's just the opposite. So is there a trend here, or will nursing homes push back?
That's a really good question. I mean, obviously it can vary a lot by state, but I would say that overall what you're really seeing is higher levels of acuity and a push to take patient or residents who have higher levels of acuity. That's just the way that things have gone for a while. There's no reason to think that that's going to change. And of course, to keep in mind that on the SNF side, that's happening too. And that, I go back to what this Midwest nonprofit group said, which is that they see SNFs moving more towards what you might think of as a hospital system, while assisted living may be more like a SNF. So I would say that increased acuity is definitely the way that things are headed in most places. I'm sorry if that's not the answer she wanted to hear.
Well, if not, she can come back with a follow-on, so we'll keep an eye out for that. Thank you so much. And this one for you, David, and Susie's asking, for a facility with 34 rooms, what would be the estimate on how much this technology might cost?
Well, there are a number of vendors, and I really shouldn't be speaking generally. And it's very, very hard. A lot depends on the structure of the facilities, the size of the apartments. I think it would be unfair to quote a price, but I do think if Susie wants to contact us with no obligation, and we could learn a little more about the structure of her community, I think we can give her a pretty fair ballpark estimate.
Sounds like a good plan, and we have Susie's contact information as well. But Susie, if you want to give a ring, we can certainly connect the dots there. So I think we're just going to go to each of our panelists right now. It looks like we're heading up to the top of the hour. So Elizabeth, are there any comments or last words you'd like to leave our audience with today?
I guess the last thing that I'd leave people with is that you just have to really systematically evaluate what's going on in the technology in your community. And it's not that there's always, as I said, kind of a magic button, but you really have to be systematic in going through it and evaluating what's going to work best for you, what's going to be a good match for your staff and for your residents.
Oh. How about you, David? Anything you'd like to leave us with?
Listen to Elizabeth.
Excellent advice.
That's going to be my new motto. Thanks.
No, I think Elizabeth is right on. And I think we all do it. We're all, attracted to the bells and whistles. Sometimes, a little chime may be sufficient. Look at what you really need, and see how, again, as Elizabeth said, how it fits your organization culture, and make sure you're ready. There's help out there. You talk to other users, talk to some of the membership organizations like Leading Age and Alpha and ACA about identifying comparable communities and their experience. But this is an exciting time. And last, I have to say, I understand the tendency, and there always will be a next great innovation around the corner. Don't wait for it. You have old people who can benefit today. Pick a company that will provide you with that next great innovation, but use technology to improve your care for those who you now serve.
Wise words indeed. Thank you very much, David. And folks, we are at that time, and I'd like to thank each of you for joining us today and hope that you found it of value and that you'll want to join us for some future events. Again, you'll be receiving a short survey at the end of the webinar, so if you would take a moment to fill it out, we do value your time as well as your feedback. Additionally, for those questions we couldn't get answered on air, we will have Care Innovations reply to you directly as soon as possible. And a copy of today's recorded webcast will be made available as an on-demand viewing, and it will come in the way of an email with a link to it. Special thanks to our guests, Elizabeth and David, as well as our sponsor, Care Innovations, and our behind-the-scenes logistics producer, Patty Van Hooser, all for making today possible. And again, as your moderator, Lori Dearman, saying thank you and have a great rest of the week. Goodbye for now.